All right, welcome to this rapid fire explainer. Today, we're acting as your elite medical tutor, systematically breaking down the exact lung abscess features test makers use to trap you. Look, if you're prepping for your board exams, you already know they don't just test your knowledge of random facts. They test your ability to spot and avoid carefully laid traps. So let's dive right in and turn those traps into easy points, shall we? But hey, before we jump into the specific exam traps, let's establish our baseline. A lung abscess isn't just your run-of-the-mill pneumonia or standard bacterial infection. No, it strictly requires actual necrosis and cavitation of the lung parenchyma. Clinically, examiners define it when it forms a single, dominant cavity that is greater than 2 centimeters. If you don't see that necrosis and that physical space on the imaging, you are simply not dealing with a classic lung abscess. Okay, here is your rapid-fire hit list for this explainer. Primary versus secondary abscesses, the gravity trap, microbiology and putrid clues, the metronidazole exam trap, Lemierre syndrome, and finally, prognosis and surgical triggers. Let's hit part 1, primary versus secondary abscesses. This is the very first clinical fork in the road when you're reading a question stem. You absolutely need to memorize this contrast. About 80% of the time, you're looking at a primary abscess. What does that mean? It means it's an aspiration event bringing anaerobes down into the lungs of a patient who has zero underlying pulmonary or systemic conditions. But if the vignette mentions a bronchial obstruction, like a tumor or a foreign body, or if the patient is immunosuppressed from HIV or a transplant, or if there are septic emboli, you need to immediately pivot your differential to a secondary abscess. That underlying condition literally changes everything about how the patient presents and how you treat them. Moving right along to part 2, the gravity trap. Now we shift from what caused the abscess to exactly where it lands in the body. Think about the anatomy for just a split second. When a patient aspirates oropharyngeal or dental bacteria, it's not some random dispersion. Gravity and the physical structure of the human airway strictly dictate the destination. Those bacteria follow gravity straight to the dependent segments. A super quick mnemonic for the boards is post-up, sup-low. Posterior upper lobes and superior lower lobes. Furthermore, they heavily favor the right lung. Why? Because that right mainstem bronchus is so much less angulated than the left. It essentially acts as a straight, rapid transit water slider for bacteria straight down into the dependent right lung bases. All right, part 3, microbiology and putrid clues. So you know where the abscess is located. Now let's identify exactly what's growing inside it, using a vivid sensory detail that board examiners absolutely love. Listen, if the clinical vignette mentions foul, putrid-smelling sputum, breath, or empyema, do not overthink it. That specific sensory clue is virtually diagnostic for an anaerobic lung abscess. Examiners use the word putrid as a flashing neon sign pointing directly to anaerobes. But here's the critical detail you have to remember for treatment. Primary abscesses are polymicrobial. They contain classic anaerobes. Just think Pepto, Fuse, Prev, and Bac for Peptostreptococcus, Fusobacterium, Crevatella, and Bacteroides. But crucially, they also contain microaerophilic streptococci. The big takeaway here, you aren't just fighting one type of bug, you're fighting a mixed polymicrobial army. Which brings us to part 4, the metronidazole exam trap. This is the climax of our explainer. It's the ultimate treatment trap that test makers love to deploy to catch you off guard. So your first-line weapon is clindamycin, and it's clinically superior to penicillin. Why is that? Because those oral anaerobes we just talked about actually produce beta-lactamases, rendering your basic penicillin completely inadequate. As an alternative, you can use a beta-lactam combined with a beta-lactamase inhibitor. Think IV ampicillin sulbactam transitioning to oral amoxicillin clavionate. Both of these options beautifully cover that entire polymicrobial profile. Seriously, burn this image into your brain. Warning, do not fall for the trap of selecting metronidazole by itself just because you saw the word anaerobe in the question stem. I guarantee you the test makers will offer metronidazole as an answer choice, just hoping you reflexively click it. So why does single-agent metronidazole fail? Well, while it's fantastic at killing anaerobes, it completely misses the microaerophilic streptococci co-conspirators. Because primary lung abscesses are polymicrobial, missing the strep guarantees treatment failure. If you absolutely must use metronidazole, you have to combine it with a beta-lactam. Otherwise, just stick to clindamycin or ampicillin sulbactam and sidestep the trap altogether. Okay, part 5, Lemire's syndrome. This is a classic board favorite eponym. It's this fascinating, somewhat terrifying sequence of events linking a simple sore throat to catastrophic lung cavities.
You really need to understand the domino effect of Lemire's syndrome. Step 1, it starts with a nasty pharyngeal infection. Step 2, the infection spreads to the neck and carotid sheath, causing septic thrombophlebitis in the internal jugular vein. Step 3, that infected clot fires septic emboli directly into the bilateral lungs, creating multiple secondary lung abscesses.
Let's break down the exact clinical profile you'll see on test day. The patient will almost always be a young, otherwise totally healthy adult. They'll show up with lung issues about 1 to 3 weeks after having a really bad sore throat. The classic bug doing the damage? The gram-negative anaerobe Fusobacterium necrophorum. To diagnose it, you need a CT of the neck and chest, looking specifically for that IJV thrombosis and those cavitating lung nodules. For treatment, you'll reach for a beta-lactam/beta-lactamase inhibitor. Note that the use of adjunctive anticoagulation for the clot remains a bit controversial. And finally, part 6, prognosis and surgical triggers. Let's look at the numbers and the strict clinical triggers that tell you when antibiotics just aren't cutting it anymore and a surgeon needs to step in.
The mortality statistics here are pretty stark. While primary lung abscesses have a remarkably low mortality rate, we're talking around just 2% with proper treatment, secondary lung abscesses can carry a devastating mortality rate of up to 75%. That is a massive jump, and it's entirely dependent on the severity of the patient's underlying condition and the specific pathogen involved.
So, how do you know when a patient is in real trouble? Be on high alert if your patient hits any of these red flags. If they're over 60 years old, if their culture comes back showing aerobic bacteria instead of the usual anaerobes, if they present an active sepsis, if their symptoms have been dragging on for more than 8 weeks, or crucially, if imaging shows an enormous cavity larger than 6 centimeters. These are the signs that antibiotics alone probably won't be enough. You've got to track the management timeline carefully. You start empiric antibiotics on day 0, but keep a close eye on day 7. If there's no clinical response after a week of appropriate antibiotics, or if that abscess is over 6 to 8 centimeters right out of the gate, it's time to pivot. You must reassess and heavily consider percutaneous drainage or surgical resection. Now, if they are responding to the meds, you're looking at a minimum of 3 to 4 weeks of therapy, and that often extends to 6 or even 14 weeks. The golden rule? You keep treating until imaging shows the abscess has completely cleared or left nothing but a small, stable scar.
By internalizing these why mechanisms, like why the right lung is so vulnerable, why the sputum smells putrid, and exactly why metronidazole alone is a guaranteed fail, you aren't just blindly memorizing facts, you're actually understanding the disease. So when test day finally arrives, will you successfully navigate the anatomy and microbiology, or will you fall for that single agent trap? I think we both know the answer. Keep reviewing these core concepts, stay focused, and go crush that exam.